Good afternoon. Possibly this is the last talk of this AIOS. And without Roshmi's permission, I took the liberty of changing the topic to just beyond surgery to avoid during, before, and beyond surgery. But I'll do it in 9 minutes. I didn't have much to say beyond surgery. Anyway, these are situations where you can actually avoid surgery in a malignant tumor. Obviously, this is a young individual who comes to you with a acutely enlarging upper eyelid, highly vascular lesion with loss of eyelashes. Obviously, it's a malignant lesion in a young individual, HIV positive, Kaposi sarcoma. Earlier, we would do biopsy in these patients with disastrous consequences and then do radiation and chemotherapy. They're already immunocompromised, chemotherapy, they don't tolerate well. Now, we simply do heart therapy. If they're already on heart therapy, there is a heart plus therapy. Now, you enhance their heart therapy and their immunological profile, and you can see how nicely the lesion, initially it may show some changes of enlargement, but finally it goes on to involute completely. So this is one situation where, given the clinical history that the patient is HIV positive, given the obvious clinical picture, you don't even have to do biopsy, you up their heart therapy and the tumor is gone. Basal cell carcinoma is the most common tumor in western part of the world, but even in India, we see it more frequently now. This is one form of basal cell carcinoma where surgery needs to be avoided and radiation needs to be avoided. We have to do medical therapy here because with each surgery, you're only disfiguring the patient, and at the margin of the surgery, a new tumor crops up. If you ever to do radiation in Golin-Gott syndrome, which is the cancer predisposition syndrome, they anyway have DNA repair mechanism abnormality, so they will crop up with more and more tumors. This patient unfortunately has been treated with radiation, and she cropped up hundreds of tumors all over the face following radiation. So in such patients, you have to look for other associated features like calcification of Fox cerebri, odontogenic keratosis, palmar pits, and then that confirms the diagnosis. There's a nice genetic test now. Golin-Gott's gene has been identified, and with that, the diagnosis for the family, rest of the family, becomes easier to screen them. And in such patients, what is really new is using of targeted therapy. Vismodegib is what is used with very nice results. The tumor simply gets erased off their face. All these tumors go away. What is left may actually be an involuted, benign part of basal cell carcinoma. Basal cell carcinoma without any atypical cells. So that remains stable. You don't even have to excise it. Earlier, we would excise them and send for histopathology. Now, you really don't have to do it. Problem with this medicine is that you have to continue it lifelong as the patient is alive, otherwise it will come back, and it is expensive. Now, a new offshoot of this treatment is that even in patients who don't have the mutation, this can be used. So if you have a patient with orbital extension of BCCA, with one-eyed patient, in such situations where we may earlier do exenteration or give radiation with loss of vision, we can use Vismodegib now with very successful results. Similarly, for squamous cell carcinoma, we have HER receptor antagonists. A lot of medicines are coming up, targeted therapy is coming up in head and neck squamous cell carcinoma, which are aimed at HPV virus or otherwise. If there is HPV virus positivity, there is a set of medicines. If there is not there, then there is another set of medicines, both of which are under trial, which are coming up very heavily in advanced head and neck squamous cell carcinoma. So that will be available for eyelid tumors as well. Now, for sebaceous gland carcinoma, the standard treatment, as has been explained, is surgical excision, cryotherapy, etc., etc. What is also important is to do map biopsy. But is map biopsy really important? Two of the speakers touch upon the fact that even for that frozen section may not be important. But is map biopsy important? We did a small study where we had a subset of patients where map biopsy was not done and a subset of patients where intraoperative map biopsy was done, and there was not much difference in outcome. And map biopsy was actually positive in 7 of 69, that is 10%, but in it was positive, the clinician had already suspected it very strongly in his clinical evaluation. So only one case was missed without the clinician having suspected it. Right? So what are the basis for suspicion? Basis for suspicion is that if there is diffuse thickening of the eyelid beyond the obvious tumor, this is the obvious tumor, and beyond that even the lower lid is thickened, loss of meibomian gland architecture in the lower eyelid or beyond the tumor, loss of eyelashes beyond the obvious tumor, surface telangiectasia, diffuse conjunctival congestion, and the thick ropey discharge. If you have all these features, limited in all of them or some of them, then you may clinically suspect that the patient has pituitary sebaceous gland carcinoma, and there is some value in doing map biopsy. In the absence of this, if a tumor were to be as crystal clear as this very nice tumor which is very focal, white eye without any feature that I mentioned just now, then you may not want to do map biopsy. So that is one offshoot of the information that we have. And what about the post-surgery protocol? In histopathology, you should look for known risk factors. When I go back and check my own histopathology reports when a patient comes back with recurrence, some of these patients come back after 7 years, 6 years after recurrence, and you go back and check their histopathology, the pathologist would have mentioned in some corner of the report, not in a descriptive way, not in the summary, that the patient has perineural invasion or intraneural invasion or vascular emboli. And those are the patients who finally may have regional lymph node metastasis, or they may have orbital recurrence. So in such patients, there is a protocol which is being experimentally tried at many centers in the West as a multicentric study, where they give external beam radiation in patients who have histopathological high risk factors in sebaceous gland carcinoma. We also look for fixed frozen correlation. Well, frozen section has given you margin negativity, but has the fixed section shown any abnormal cells in the area where margin was reported to be negative in frozen section? In frozen section, the pathologist is in a hurry, surgeon is in a hurry. There is a frozen fixed mismatch of about 5 to 10% depending on the center that you work with. What if the margins come positive? Despite your frozen section, despite your deferred reconstruction, finally, in the final pathology report, which is a medico-legal document, if the margin is mentioned positive, then what do you do? Or you haven't done anything, you haven't done frozen section and the margins are positive. It depends on whether you have done whether there is a lamellar positivity. That means if the anterior lamina is positive or the posterior lamina is positive. And have you performed a shared lid technique or a non-shared lid technique for reconstruction? If there is full thickness invasion and you have performed a shared lid technique, then the lower lid, if you have reconstructed the upper lid, lower lid might also get the tumor. So you have to be very careful in this situation. So the advice here is, since you can't go back and excise and also not deal with the lower lid surgically, to give radiation in sebaceous, squamous and basal cell carcinoma as adjuvant therapy. But if only one lamina is positive, possibly you can do cryotherapy at the second stage of reconstruction, or if you already performed your stage 1 reconstruction and there is no need for second stage, go ahead and do a cryotherapy. What if map biopsy is positive? If the entire surface of the eye is involved, 360 degree, all map biopsies are positive, one most important treatment that is available is orbital exentration. If patient doesn't accept it, or you think that the vision is so good, I don't want to do orbital exentration, let me try other means. First thing is to occlude the puncta, because there is a entity called onchoria where the tumor cells actually get into the lacrimal sac. Even after exentration, they might come with an intranasal tumor. We have had situations like this. So occlude the puncta and do topical chemotherapy with topical mitomycin C. There's about 50 to 60% chance that the tumor will go away. And with the conformal brachytherapy we currently have, where the symblepharon ring has ruthenium emulsion on both sides, you can treat the entire ocular surface without treating the cornea as such. So that option is available for patients with map biopsy positivity. Regional lymph node positive, of course, you have to do regional lymph node excision, which could be radical neck dissection followed by radiation. If there is gross residual, they need resurgery. Diffuse sebaceous gland carcinoma often warranted orbital exentration, but now we have a nice chemotherapy protocol which is more or less established, that if we do chemotherapy, the tumor volume reduces to about original volume to about 60 to 70%, which is not bad enough to perform conservative surgery. In many situations, you might end up with tumor volume grossly reduced, as you see here, now being amenable to conservative surgery rather than orbital exentration. So chemo reduction in a diffuse tumor, or when the patient already has regional lymph node extension, or for tumors like this with both the lids and the lateral canthus are involved, are definitely a good option in sebaceous gland carcinoma. You can see this patient obviously needed orbital exentration, no doubt. We tried chemo reduction, no doubt. Tumor has reduced so much, but still she needed orbital exentration. This is one odd case where we still had to perform orbital exentration despite the tumor having reduced so much, because there was still a large orbital component left. Sentinel node biopsy has been covered, prognostic factors have been covered. So in conclusion, I would say that there are now options available for management of malignant eyelid tumors where surgery need not be performed at all. Medical treatment is available. There are situations when treatment before surgery may be useful in conserving the eye and life, as in neoadjuvant chemotherapy or chemoreduction. Exactly the same mechanism has been applied for basal cell carcinoma as well. Very limited vismodegib therapy to reduce the tumor and then go and remove it surgically. So you can chemo reduce it to your advantage. Approach to a patient beyond surgery is definitely guided by histopathology and possible risk for tumor recurrence and systemic metastasis. Thank you so much.